I am the clinic chief of hepatology. So in one of my administrative role, I'm responsible to understand how our practice has changed not only during the COVID-19, how do I look at the future for our hepatology practice. At the same time, I am part of AASL, the COVID-19 working group, and through my experience by working on this group, I can give a little bit background and also try to predict how the future in hepatology holds. The objective is of my talk would be post-COVID-19 impact on patient and liver care, on trainee education, and overall on physician well-being. Sorry for the typo on this slide. Let's start with a question. And it's not actually a question, it's about how do you all feel? What is your main concern regarding post-COVID-19 era? Are you worried about the financial concern that is during and post-COVID-19? Are you worried about second wave and exposure to infection? You're worried about increase in liver diseases and missed cancer rate? Or you're worried about overall mental health and anxiety and what we call post-traumatic disorder during this COVID-19 era? And there's no right answer. It is basically everyone would have a different concern. So I just wanted to get an idea how we are thinking about COVID-19 individually. So during COVID-19, we were all focused about taking care of these patients, but this is an untold toll, which is what is this pandemic's effect on patients who did not have COVID-19? On Washington Post, which is one of the important newspaper, this headline, which got a lot of press, is patient with heart attacks, strokes, and even appendicitis vanishes from the hospital. We all know that during the COVID-19, patients and family members were worried about coming to the hospital. They were worried about taking care of their normal health. And with this COVID-19 cases now up to 31 million, which close to 1 million deaths, in America alone, we have 200,000 deaths already through COVID-19. Despite that, we still have many patients who does not have COVID-19 who has delaying their regular medical checkups and care. So before COVID-19, we already knew that there are certain disparities in liver health which is now worsened by COVID-19. We already know that there were some population, they were delaying diagnosis of liver disease or cancer, which will gonna get worse during and post COVID-19. There was still decrease in access to care and transplant, which is also gonna be worse after COVID-19. So delay or lack of treatment, and there are certain increase in exposures and risk factors where patients were getting increased disease, whether it's IV drug use or other risk factors, including alcohol, that will worsen after COVID-19. There was also one important impact of COVID-19, which was even before that, is the financial impact. And COVID-19 recession is the fastest and steepest downgrade in consensus in America. If you look this, where the global GDP has significantly as compared to the downturn in 1991 or 2009. And this negative impact of the pandemic has disproportionately impacted population who were likely to be below the poverty level prior to economic crisis caused by COVID-19. And this will only gonna get worse in the future, not only in overall healthcare, but also especially in liver-related healthcare. So I wanted to pay your attention. This is a very good paper from Dr. Tapper, which was published in Journal of Hepatology in April of 2020. And what it talked about is impact of on the cirrhosis care of COVID pandemic. And when we look at that during the first wave, that when we started having, we were prioritizing high equity care, taking care of patients with COVID-19. There was delayed in liver transplant, including living donor transplant. There were selected disease donor that was happening in the United States. Elective procedures were getting delayed, imaging, routine patient care. When this first wave was coming down, then the second wave we would be seeing, or we already seeing, emergent decompensation. Patients who were delayed in taking care now coming in with hepatic decompensation. In our US, we were worried about transplant waitlist dropout. In Pakistan, patients who were not getting living donor, they may die while waiting. There was a huge backlog of visits or patients who were not seen or all the tests. Then there would be years down the road, there would be a third wave. That is, patients who lost insurance or from financial reason, they were not able to schedule visit. There would be a lot of misdiagnosis. There would be incomplete cancer screening and progressive liver disease. So this COVID pandemic impact, which we are already seeing right now on the first wave and some places of early second wave, it will be years down the road that we will have a post-COVID-19 impact on liver care. So as physicians, as hepatologists, how do we manage this? How do we work around it so that we have less patients who have emergent decompensation, less patients who have missed diagnosis of cancer or other diseases? At the same time, we also worried that in places where there will be a surge, where will be a second wave, we will go back to this first phase, meaning that if in Pakistan, the cases are way down of COVID-19, but if unfortunately, if we see an increased surge, we may go back to decrease in elective procedure, routine imaging. And so during this time, when we have decreased cases, how we can see patients in a timely manner. And this is, it's in progress. Every place is figuring out how is best manage these patients. So post-COVID-19 and liver disease, how do we look into it? So post-COVID-19, we will all see increase in liver cancer because of misdiagnosis. I'll show you some data. We will see increase in liver disease because of alcohol, obesity, and viral hepatitis. We all are seeing decreased treatment for hepatitis C and other liver diseases. And also, we have been seeing, or we will see, worsening mental health issues in patients with liver disease. So at UCSF and a lot of other places, we started thinking about what is our recovery challenges, like post-COVID-19. What is the plan that we can come up with so that we can provide the best care possible, not during this pandemic, but also post-COVID-19. And this can be different for Pakistan or different institutions. But the key message I wanted to give it that everything we do, the patient care or patients is the heart of or center of what we wanted to do. The first thing is how do we prioritize the safety of our staff and patients, whether in the hospital and clinic setting. COVID is not going, and even with post-COVID-19, despite the if we have immunization available, there would be still cases. So we still need to have our good protocols that do have COVID symptom check in patients who are coming to the clinic or in the hospital. How do we maintain social distances in the clinic? How do we make sure the safety policy and masking policies remain intact until we have clear guidance from our authorities? And how do we make waiting room changes so that we don't have many people coming at the same time, or they have seating so that we can maintain social distancing? What about the clinic workflows? Now with the cases coming down or post-COVID, how do we prioritize urgent patients so that patients who have cirrhosis, patients with liver cancer, patients who are much higher risk of decompensation, how we will able to see them early? How do we go back and make sure that the new referral we are getting we can see that? And also, how do we communicate with the patients before the clinic so we can tell them what safety measures needed to be taken so that patients feel safe coming to you or your clinic or your hospital? Resource utilization is a very important part of our planning post-COVID-19. How do we optimize and have flexible schedules so the patients who have difficulty seeing us, whether because of time or because of the day, we can increase your schedule or make the adjustment or even on the weekend so that we can see these patients? How do we implement more telehealth, and how do we actually spend money so that this telehealth, which I'll talk about a little bit later, is here to stay. What is the other digital technology platform? And in Pakistan, what is the electronic medical record implementation? Because what COVID-19 has taught us one thing, that technology has a huge impact on it, and how we can improvise it and use it for the future would be very important. And lastly, communication is the key, not only during this pandemic, but also post-COVID-19. We need to pay extra attention post-COVID-19 on vulnerable population. We also have to protect ourselves, and we need to understand if our physicians, our trainees, or our support staff are getting burned out, and address our own health need, and continue to focus on trainees' education, not only during this time, but also post-COVID-19. So this is the data from the US, from an institution, to show that what is the COVID-19 will have an impact of cancer diagnosis. And this pandemic effect, we will see many missed cancer diagnoses. So breast cancer, prostate, and this is also in colorectal cancer because of decrease in the screening. There is a significant, during the pandemic, in the month of February and the first 3 months of pandemic, we've seen 87% decrease in mammograms, pap smear, colonoscopies were decreased early on 90%, CT scans were down 40%, PSH testing was 60%. So these are all the screening methods that we were doing for screening cancer were way down, and it's slowly inching up back again. But we will see again a lot of missed cancer diagnosis. In our liver patients, and besides the liver cancer, they are also at risk of all these other cancer. And if unfortunately our liver patients do develop any of these cancers, the treatment is even much more complicated. So not only we have to talk to our patients that not to have missed cancer diagnosis of HCC, but all the other screening they should be doing. So the first point is that we have to continue to be very vigilant for hepatocellular cancer surveillance. And early on, when the pandemic started, based on our ASLD guideline document, we were saying that HCC surveillance should still continue as close to be possible. But early on, we were okay with 2 months arbitrary delay was acceptable. But now with the COVID situation better, we want these patients to get the HCC. So at UCSF, we are working on all the delayed imaging and prioritizing them. Obviously, patients who have known HCC or patients who have been treated or elevated alpha-fetoprotein, we're getting their scans right away. But now everyone is coming back. Communications with patients are the key during this pandemic and also post-COVID, that importance why it is safe for them to get these imaging and what are the risks that if they don't get these imaging or surveillance. Also, we should not delay any HCC treatment. And this is very, very important. If you have a diagnosis, not only during the pandemic, especially post-COVID, we need to make sure these cancer patients get their treatment as soon as possible. Now, I know that Dr. Foster will be talking about hepatitis C elimination or viral hepatitis elimination. I just wanted to briefly talk about post-COVID-19 and COVID-19 impact. So we worry about that there would be an increased hepatitis C infection. There is concern for increased risk behavior and IV drug use. We're already seeing reduced hepatitis C screening. There is one of the articles suggested even in Egypt, there was a 50% decrease in screening rates. Decrease in Hep C treatment, we're already seeing that early on. Most of our primary care and hepatitis specialists were also taking care of COVID-19 patients, and patients were scared, and they were not seeking care for hepatitis B and hepatitis C. Because the perception of patient, the risk and benefit are changing. Again, that there will be financial impact, which will be even worse post-COVID. And also, we are seeing lower rates of vaccination. So if you talk about hepatitis B and other testing, so these will have a major impact on our viral hepatitis elimination programs. We all know about the hepatitis C elimination program by WHO by 2030. The target were 90% diagnosed, 90% reduction in new infection, and 65% reduction in liver-related mortality. So, you may know about this, but it was before COVID, that with the current strategies before COVID, most countries are targeted to meet this 2030 goals by which year? And before COVID, it was 2050. And unfortunately, the COVID impact and a lot of other, because of the funding of WHO by US, we will see that this would have even a, even worse impact on the Hep C elimination effort. And I am really worried about this overall the condition that we will be seeing in the future regarding viral hepatitis elimination. This was an important paper from Dr. Fasia Kawal and her group, and it was pre-COVID data that, if we not able to do anything or increase our effort from 2015 to 2030, we will see 1.4 million people to die from hepatitis C infection, and 48% of this hepatitis C related death would see in patients who are younger than 50 years. And this COVID-19 pandemic will make it even worse. And this was the other outcome that from that study. From 2030 until 2030, we will have 1.1 million people with liver decompensation, and more than close to 800,000 pre-developed people in the US, in the Pakistan will develop hepatocellular carcinoma. So we have seen the decrease in Hep C treatment in the US since COVID-19 pandemic. This is data from one of our state, Louisiana. And you can clearly see in arrow that, we have seen that decreases down from January 2019 to present. And there is other data from other states and other countries coming out. Even pre-COVID, the decrease from 2018 to 2019, the treatment was down, but since COVID, it is way down. This was just recently published article of impact of COVID-19 on global hepatitis C elimination effort in Journal of Hepatology. And what it tried to show is that what is just 1 year delay in Hep C programming relative to status quo if we don't delay what we have. If we see that in the 1 year, we will have the diagnosis would be, a new diagnosis will be way down because of decreased screening. We will have way down treatment, and then increase in the new cases of hepatitis C, increase in the liver death, and increase in viremia. And overall, based on 1 year delay, the scenario will result in about extra 45,000 excess liver cancer and 72,000 excess liver-related death relative to no delay. And it may be even worse if the COVID-19 situation keep worsening. And this will impact even more in lower socioeconomic or lower income countries. So this will have a huge impact, and we all have to pay real focus on this viral hepatitis elimination in Pakistan in the post-COVID-19 era. I wanted to give a shout out to Dr. Asad Chaudhry and the Hepatitis Echo program in Pakistan, because not only pre-COVID but post-COVID, this will even have a much bigger role in our viral hepatitis and liver education overall. And most of you are aware that this was not telemedicine, but it's an ECHO program. And I am very excited that Dr. Sanjeev Arora is also giving a state-of-the-art lecture during this PSH meeting. Now, what about alcohol and other related liver disease, and what would be the impact of COVID-19 and post-COVID-19? When I was preparing for this talk, I've gone through this article, which is and if you haven't read, this is a very well-done article by Dr. Saran Group. And what it shows that, what is the different liver diseases in Pakistan. If you look at in dark blue, alcohol is overall much smaller proportion, but we still see alcohol as a cause of liver disease in Pakistan. But most of the cases, as we know, in liver disease are viral hepatitis and some other cases. So Pakistan with hepatitis B and C is still leading as compared to other countries in Asia. We may have alcohol have a bigger impact. What we already know that the effect of COVID-19 lockdown and alcohol consumption has been significant. This is one of the study which was published in Lancet Gastrohepatology this year, where patients who have pre-existing alcohol disorder, they had these survey questions and talked with them, and there were 182 participants, And for 24% patients who had alcoholic disorder pre-existing report that they have increase in their alcohol intake. And there was a 17% patient who were stopped drinking had a relapse during lockdown. This is one of the interesting data that, if you look at the March when the COVID pandemic or, when we say shutdown in America started happening, you see the sale of alcohol increase online. This is the blue, which is 477% increase in the online sale as compared. And so even in Pakistan, and especially in America and the Western world, we will see post-COVID-19 much higher alcoholic liver disease. In our hospital, we are already seeing alcoholic hepatitis. So start paying attention. Talk to your patients who are at the high-risk group. Talk to them about alcohol, other drug use, which is very, very important. The one thing which, unfortunately, as a hepatologist or gastroenterologist, we don't spend too much time with our patients and talk to them about the mental health well-being. Because COVID-19 impact on mental health will be long-term, and in post-COVID, we will be seeing more and more of it. This was a survey in the US where they actually seen that during the May, June, or July, there is a significant increase in. So this is a symptom of anxiety disorders, which has 30%. Same with depressive disorders, 25%, and both depression and anxiety is up by 34%. And this is pretty consistent, and the more it is prolonging, the more we will see this impact. And so one advice I would have all of you is not only to monitor closely your patients with liver disease and ask them about mental health issues. Make sure they're on the right medication or to guide them, and make sure they're not going into using some medications that can impact their liver health. So this is a very important part of our post-COVID era recovery, I would say. So obesity and COVID-19. So the more and more data we know about that, if you look at the just impact of COVID-19, obesity is consistently coming as one of the major risk factors to have poor outcomes. I like this data from our CDC, where it shows that in patients who have hospitalization. So I want you to focus on this relatively younger group between the age of 18 to 49. So clearly you can see that this group, the obesity is coming as a major risk factor that they are hospitalization. So a lot of these patients who have obesity, they have other conditions, but if you look at the cardiovascular disease, mostly in the older group, but this age group of 18 to 49, obesity is a major risk factor for hospitalization. Also, there was the data from around close to 300,000 people from England, and that's what they also mentioned about the more severe your obesity, the more chance of hospitalization. Not only that, if you're obese, you have increased chance of dying or having a increased chance of dying or intubation from COVID-19. And this is again just a recently published article in Gastroenterology, and a very well done study where they looked at the US data, and they found that there were patients who had COVID-19 without obesity versus COVID-19 with obesity in blue has poor mortality or worse mortality or increased risk of intubation. So COVID-19 impact of obesity is real. However, the concern is during the pandemic and post-COVID era, the obesity will only gonna get worse. This is a nice review in Nature Reviews of Endocrinology, which they talk about that, a lot of social intervention against COVID-19 when we had a lockdown, physical distancing, and self-isolation, people are having increased socioeconomic hardship and deteriorating physical health, which lead to this chronic stress and altered eating behavior, which lead to worsening of obesity. And overall, in post-COVID-19 long-term years down the road, we will see increased risk factors of insulin resistance. We will see ectopic fat deposition, hypertension, which ultimately lead to increase in comorbidities of type 2 diabetes, heart disease, cardiovascular disease. But also at the liver side, we will see worsening fatty liver disease and NASH. So this post-COVID-19 era, we will see significant worsening of our fatty liver disease and other comorbid condition in patients with liver disease. So the other impact in overall in GI and our liver condition is we have seen decrease in colonoscopies in the US and also decrease in vaccination. This is also very, very important because of hepatitis B vaccination in our infants and overall hepatitis vaccination in the US. And in not only the other vaccination, if you see in children, all these other vaccination was significantly way down in patients with in patients during the COVID-19 and slowly going up. So point is very, very important. Please make sure your patients, and especially if they're pregnant, they are getting their vaccination on time. But the important part post-COVID, which I was thinking about, once we have a vaccination available for COVID-19, we do need to have a better understanding regarding the safety of any future vaccine, especially on our liver patients, whether there would be taking patients from our decompensated cirrhosis or other cirrhosis patient, and what would be the safety? And once they are safe, how do we prioritize that our liver patients get that vaccination? So this would be another important part of, as a hepatologist, we need to start thinking about it. Early on during the COVID pandemic, we did saw the decrease in transplantation. This is the study which has shown that they look at the data from France and USA. So they saw that as soon as the COVID-19 pandemic started to increase or new cases, you see the decrease in transplantation, all kind of transplantation, not only liver, but kidneys, heart, and same with the USA, that when you have increase in the cases, you have decrease in the transplantation. Different programs are impacted based on their geography, where they're located. At the UCSF, we saw a small decline, but now we are going back. But in Pakistan, when I was talking to my friends back there, there were some decrease in living donor liver transplant now going back. But those are important thing to go back and see which patients who still need to be going forward with the living donor transplantation, and also think about if a second wave comes in, what your program has learned during this pandemic and how to prioritize post-COVID-19 these patients who are in need for liver transplantation. But the one thing is important, we should not delay liver transplantation during this time, and especially post-COVID-19. Now, the other thing is during the COVID-19, what we have learned significantly is healthcare and digital infrastructure. So we need to have policies for telehealth. I tried to look at, but I didn't see any guidance in Pakistan or a legal document, what are the parameters of telehealth. Recently, India, I think early this year or last year, had some kind of a guidance. How do we build this digital framework for healthcare going forward? And also, what is the online security and privacy mandate? And how can we reach out to vulnerable population who doesn't have internet connection, may not have smartphones? But I think there would be this digital infrastructure, and telehealth is the future for post-COVID-19 era. Now, what about the training education? The most important thing we do I was a program director at UCSF, is how we are in this field is how we can train our future generation, right? What we saw that during the COVID-19, there was, early on in March to May, we didn't have fellows involvement in a lot of inpatient, outpatient activity, but then we started having. So there was a significant decrease. This was a study in GIE, which shows that in COVID-19, there was a decreased fellows participation in EGDs, colonoscopies, and upper GI bleed. So the training did affect it. So what would be the impact of COVID-19 and post-COVID-19, how we think about? Same with the education, just like we have to do all these meeting virtually. Pre-pandemic, we were having lecture series, we're having journal club, grand rounds, we have M&M, we have doing rounds together, but and during the COVID-19 and likely post-COVID-19, the Zoom and other technology platform will be used, but how we can improve it, how we can make it better so our trainees does not get impacted by this post-COVID-19 era. So I think there's some future direction and new opportunities. We thought about inpatient rotation and outpatient. How do we become effective in telemedicine? How do we learn to triage? How do we learn about the urgency of some procedures, and same with learning about new opportunities for didactic. But we should be continue to focus in our trainees in the post-COVID during this time and also in the post-COVID era. So I wanted to also talk about that in the US, a lot of our trainees and a lot of, there was a discussion that what is the future of hepatology looks like. And it was already a discussion going on pre-COVID whether people want to be hepatologists because it's a post-certificate field in the US after you do your GI training. This was recently an ASLT study that was done to understand the demand of hepatology. And in the US, we think that, or all over the world, the prevalence of liver disease will increase by 33% between 2018 and 2013, mainly driven by fatty liver disease. And then there would be also a significant maldistribution of hepatologists because we have more in the big cities, but rural areas would be low. So there is a big demand of hepatology, and this was pre-COVID, and I feel that post-COVID, this demand will only increase. And based on these, there would be a deficit of minus 35% by 2033. So hepatology, especially in Pakistan, with a huge viral hepatitis and a focus on viral elimination, we have a huge need for hepatology. So I encourage our graduates to think hepatology as a dedicated field and take care of these patients. Lastly, I wanted to end our talk because in the end, we as physicians are to take care of ourselves. During this COVID-19, we all have to go through and take care of these patients. So there's a lot of anxiety, stress, phobias, panic, and depression. In the US, there are around 1,000 healthcare providers who have died from COVID-19 in the US, and it's all over. So first of all, I think we should thank all of our colleagues, our friends who have died and pray for them, but also understand that how important our role is. And we are here to take care of the patients, but we need to take care of ourselves also at the same time. Mental health is a real issue in healthcare, and this will only going to get worse after COVID-19. In the US, estimated 300 to 400 physicians die by suicide. I recently reading about a Pakistani girl physician who died from suicide. So this is a huge issues with depression and anxiety in healthcare. So don't be stoic. Ask for help. Please take care, because if we are sick or if we can't take, who will take care of our patients? So please take care of yourself. I like this. If you don't make time for your wellness right now, you will be forced to make time for your illness. So lastly, what is the silver lining? Because we talked about all the bad stuff that's going to happen, but can we do anything that whether the COVID-19 can change something? Because I think we can change. This is shown. Look at the technologies and everything that has changed. We were going to the stores to get, now we're watching movies on Netflix. So this COVID-19 will only bring something positive to us and we can learn from it. And so there are a lot of opportunities because physicians and government and public working together for one goal during COVID-19, and we can take it forward, especially for viral hepatitis. We have new educational opportunities. We have new telemedicine and outreach, but we have to also create physician leaders who can work together and take care of ourselves. So in summary, post-COVID-19, we will see more decompensation of liver disease, misdiagnosis, and increase in liver diseases. Priority should be given to high-risk patients. Organizations like PSH should consider some guidelines for post-COVID-19 for our gastroenterologists and for physicians. Financial impact will remain a big concern. We need to invest in telehealth and digital platform, and please take care of health and each other.
What an elaborative talk. Thank you so much, Dr. Bilal Hamid. It's always pleasure to have your excellent presentation. Our second honorable speaker is Professor Graham Foster from the United Kingdom. Professor Foster is the professor of hepatology at Queen Mary's University of London and a consultant at Barts Health in East London. He trained in medicine at Oxford and London universities in the 1980s and completed a PhD in molecular biology in 1992. Professor Foster has a long-standing interest in the management of chronic viral hepatitis and runs a clinical research program studying the natural history of viral hepatitis its impact on patients and their communities, and novel therapies for this disease. He is the editor of the Journal of Viral Hepatitis and has published widely in the field of viral liver disease. He is the past president of BASL, vice chairman, the UK Department of Health Advisory Group on Hepatitis, and member of a number of patients advocacy groups. Professor Foster is going to present HCV elimination by 2030. Are we on the track?
Hello, I'm Graham Foster. I'm the Professor of Hepatology here at Queen Mary, University of London, and the Clinical Lead at Barts Health NHS Trust. I'm also the National Hepatitis C Clinical Lead for England, and today I'm going to talk about hepatitis C elimination and whether or not we're on track. It's always a pleasure to talk to my friends and colleagues from Pakistan, and I'm very sorry that I'm not able to be with you physically today, and I'm sorry that COVID has really taken a lot of fun out of all the liver meetings that we used to enjoy so much. But hopefully next year we'll be able to physically meet up instead of meeting in cyberspace. But whilst COVID has disrupted many of our plans, I think hepatitis C elimination is still something that is on track. And what I hope to do today is to persuade you that this is still a virus that we can eliminate. Here are my conflicts of interest, and here's what we're going to talk about. I want to start by talking about how we measure hepatitis C elimination, because I think we've rather underestimated how difficult this might be. I then want to talk about where we are, and then we'll finish up with a chat about what else we need to do. And when I talk about elimination, of course, we all know what we mean, and we've got some very clear guidance, some very clear targets from the WHO. Who could argue with these very precise, very clear numbers? The incidence has to go down by 30%. We've got to increase the proportion of people who are diagnosed, reduce the number of people who are missing out on treatment. Some very clear, very tight numbers here that will allow us to judge whether or not we've eliminated hepatitis C. There's one problem, of course, with all of those numbers. Where are we starting? What's the starting number for incidence, number diagnosed, proportion aware of their diagnosis? What's the starting number for these very clear targets? Well, I can tell you in England, we're on a very sticky wicket indeed. You can see from this publication from Public Health England, looking at the prevalence of hepatitis C, it's all very nice and clear for people who use drugs, nice, tight confidence intervals. But look here at the bottom. There's a huge pool of people where we're not sure how many are infected. So I have to reduce hepatitis C prevalence by somewhere between 0 and 150,000 people. That's not a target we can ever achieve. So it's going to be very difficult for us to achieve hepatitis C elimination because we'll never know when we've done it. So we haven't got a clue. We really are floundering when we come to thinking about elimination and how we're going to prove that we've done it. So what about you folks? What about Pakistan? Are you better off than we are? Well, the answer is you really are. And all I can do is step back in awe and admiration of the data that the people in Pakistan have generated. And this, of course, has been led by Huma Qureshi, who did that extraordinary national study looking at the prevalence of hepatitis C in a huge cohort of people. And that has really given you what I think is world-class data on the prevalence of hepatitis C. Here's a publication from 2009, a systematic review. Most of us don't have enough papers to do a single review, never mind a systematic review. So this is really testament to the very high quality public health work in Pakistan. What you know is that around 2010, you had about 5% of the population infected. And look at those terribly tight confidence intervals. You've got a very good idea of what your prevalence is. You can break it down by age groups, look at the pediatric population. You can break it down by injection drug users. But Pakistan really is one of the few countries where you know your starting position. And that's a very strong position to be in, because it means you've got something to measure. You can assess your progress. So when we look at incidence, proportion diagnosed, proportion treated, you do have uniquely a starting number. But all you have to do is repeat that every year. If you repeat the national survey every year, you can monitor your decline, you can change tack, you'll be in a very good position. Are you really going to do that? This is just not realistic, is it? You can't keep measuring the number of people. You can't keep repeating a random survey. It's going to be very difficult to know whether or not you've eliminated hepatitis C. So if we can't use new cases, if we can't use treatment rates, if we can't use prevalence of the population, what can we measure? And here we've got a very nice target from the WHO. That's mortality. That's pretty easy to measure. You're either alive or you're dead, and most people know the difference. So we can measure mortality, and we can measure mortality in people we think have hepatitis C. But there's a problem here. And the problem, I'm afraid, is that when you clear hepatitis C, people still die of hepatitis C. Here's data from the English Early Access Programme. We focused here on people with advanced decompensated cirrhosis. We cleared their virus with oral antivirals, and you can see there was a significant reduction in adverse events. And adverse events, I'm afraid, means death or transplantation. But you can see it didn't go down to zero. People were still dying of hepatitis C. Not as many, but still plenty of deaths. And worse than that, we know that the risk of liver cancer persists after you've cleared hepatitis C. Here's data published in Gastroenterology looking at 10 years, a decade after clearance, and still seeing an increased rate of liver cancer. So it's perfectly possible that you will eliminate hepatitis C completely, and deaths will still go up. Now, long term, of course, in the very long term, with fewer new infections, with fewer people with mild disease progressing to cirrhosis, we'll see this very significant fall in morbidity and mortality. But a lot of people with mild disease will not die, but a lot of people with severe disease may well end up dying of hepatitis C related complications. And I think this is a very important point that we need to make to our politicians now, because death rates in the medium term may increase. If you have people with cirrhosis and you diagnose their hepatitis C and you treat them, of course they won't die of decompensated cirrhosis, but they'll live a long and healthy life and they may get cancer. So they won't die this year or next year as they would without treatment, but in 5-10 years' time, they'll die from their liver cancer. So viral eradication may not reduce mortality by 65%. And you may see, because you're diagnosing more patients, you're making a hepatitis C diagnosis for a death certificate, there may be actually be an increase in deaths in the medium term. So some really important messages here from the long-term outcomes from hepatitis C treatment. We need to be aware that doing it well might mean that we see more cancers, more deaths in the medium term. That's not to say we shouldn't be curing and eliminating hepatitis C, but we need to be careful about how we measure things. And the WHO targets, I'm afraid, cannot be measured. We do not know what the starting point is. We cannot routinely assess incidence. We can only model it. And models, of course, are only as good as the data that goes into them. And mortality is not a good indicator. So we have this difficult position that we need some new metrics. And the metrics, in my view, need to be based not on relative change, what proportion of people, but on absolute numbers. And Homi Alazevi has pulled together a panel of the great and good who are arguing very strongly for a change in the WHO targets to something that we can measure. And we're planning to hold an EASL conference in March 2022, trying to address this in a little more detail, trying to find out some measures that are appropriate, measurable, and we can all rely on. So at the moment, I don't think you need to worry too much about elimination because no one knows what it looks like. So where are we? How far have we got, and are we making any great strides? Well, a lot of people have been looking at Pakistan as a country with a high prevalence of hepatitis C, modelling what's going on. And this is one study from Peter Vickerman's group. And this looked at modelling. So it's a modelling study. And all modelling studies do have a big defect that they're based on assumptions, not all of which may be correct. But I think this is a very powerful group. You can see a lot of high-quality Pakistani people were involved in it. And I think it's probably as good an estimate as we've got at the moment. But you can see from the charts that if you take the starting position of 2016, even if you do an awful lot of work, reducing the risk of transmission, improving treatment outcomes, it's still going to be a pretty difficult ask to get to elimination. And in simple terms, you're going to need to work really hard because the number of patients per year that you need to treat is going to be very, very large indeed. If you carry on with the current treatment rates, about 150,000 people treated every year, and that's not a bad rate, your prevalence of hepatitis C is going to increase, not decrease, but increase. If you want to hit the WHO elimination target, you need to treat nearly 1 million people every year. That's a huge target. You can reduce that a little bit by increasing prevention. And I think that there are some really important steps that the Pakistani government and the Pakistani clinicians are doing to reduce transmission. And I commend you on all of those really important initiatives. And I think that the opportunity to halve transmission risk is very real. All the needle syringe destruction programs, the single-use programs, the cleaning up of blood transfusion services, these are all non-glamorous but really important steps on the road to elimination. And I know that you're well underway implementing these essential steps. And with those, you can reduce the number of treatments you need from nearly 1 million to nearly 500,000. So it's only 500,000 a year, folks. That's a big ask. 500,000 therapies per year to eliminate hepatitis C in Pakistan. That is a very big ask. But it's doable. Here's the Egyptian model. The Egyptian government went for hepatitis C elimination. They went for it in a very big way with a presidential program. You can see here the publication in the New England Journal earlier this year. And if you look at these figures, they are absolutely extraordinary. In little over a year, getting on for 400,000 people were cured of hepatitis C. And that is a spectacular performance by any standards. And I think we really have to stand back and applaud what the Egyptians have done. They've taken this virus and attacked it with everything they had at their disposal, and you can see what they've achieved. They really have done extraordinarily well. And if the Egyptians can do it, anyone can do it. I remember a conversation with Gamal Esmat. Gamal, of course, played a seminal role in the Egyptian elimination campaign. And I was moaning a bit about working in England, the NHS, and how difficult it was to get anything done. And he said, Graham, we've had 3 revolutions and we're still eliminating hepatitis C. And he's right. If you have the will, then you will find a way to do it. And the trick in Egypt was to get political support for the elimination campaign. And I do believe that with the Pakistani program, there is that political support. The governors of the provinces are buying into this, and you are starting to get the political traction that you need. So I do believe that you can follow Egypt in eliminating hepatitis C. I think that Pakistan has a good chance with the infrastructure you have of getting to these 500,000 treatments per year. So the Egyptians can do it, and so can you. But Egypt had a soft genotype. Egypt, of course, had genotype 4. And in Egypt, we know that soft DAC cured 98.8% of people. So is soft DAC going to cure 99% of people with genotype 3 in Pakistan? That's a big ask for genotype 3, which is that little bit more refractory to treatment. And of course, in Egypt, it was a single event, the schistosomiasis vaccination campaign, that led to these very high rates. Whereas in Pakistan, there's still ongoing transmission. And there's a real risk, of course, that people will reinfect. And if you start to eliminate and you get resistant virus that's reinfecting people, you could spend a lot of money eliminating hepatitis C, only to find that everyone's getting reinfected with resistant strains. So there is a real risk that the program could be derailed by reinfections and resistance. And I just want to show you a little bit of data that may just cause you a moment of anxiety. This is data from my own group, looking at genotype 3 hepatitis C and looking at a resistance mutation in the polymerase protein, A150V mutation. And that confers resistance to sofosbuvir. Interestingly, it's now just been reported in genotype 1 disease as well by the Dutch group. And there does seem to be this odd polymerase mutations, quite common in genotype 3, that reduces the response to sofosbuvir. Now, we've known for a long time that people who failed to respond to interferon didn't do very well with sofosbuvir if they had genotype 3. So we looked at this mutation and we looked at what interferon did to it, and you can see here, this is a mutation that stops interferon working. And the way it stops it working is interesting. It doesn't stop interferon signaling. This is laboratory data looking at interferon signaling with a wild-type hepatitis C replicon and the mutated replicon, and you can see they both seem to respond exactly the same. You look across, there's a lot of non-significant stars on all of those bars, and there's no significant difference. Where there is a difference is here. The difference here is that in this gene, the PKR, the phosphorylation in the presence of A150V, is reduced. So what the A150V mutation does is to inhibit the PKR protein from working, and you can see that very clearly on the bar charts. So what does PKR do? Well, PKR is a tumor surveillance protein. It induces apoptosis and kills off malignant cells. So when we looked at cell death in patients with the A150V mutation, you can see here that if you have the wild-type virus, your cells will apoptose and die if they're turning malignant, but they don't with A150B. So this might be a cancer-causing mutation that predisposes to malignancy. And that might be something we could use to stratify for liver cancer, but it also, of course, raises the terrifying possibility that if you're resistant to sofosbuvir, you might still have a predisposition to malignancy. And that's something that we are planning to look at, along with Saeed Hamid, Saad Niaz and Huma Qureshi. We're starting a very large program in Karachi, and I'm pleased to say with Navid Chowdhury, we're moving that up to the Punjab. So we're going to start looking at this and doing some research just to see if this theoretical possibility is going to be a real problem to us. I can't leave a talk on elimination without mentioning the C word, the COVID virus. And we're all very concerned that COVID is going to hamper our elimination drive. Now, this is a modelling effort looking at the impacts. And you can see here that in a lot of countries, particularly America, COVID is going to really distort their plans to eliminate hepatitis C. You can see England's going to be very badly hit. But fortunately, in Pakistan, the impact of COVID we estimate to be relatively slight. That doesn't mean to say it's not going to have any impact. But the view is that COVID in Pakistan is probably not going to derail the elimination program. So I think you are in a fortunate position that your program is at a stage where COVID isn't going to derail it. You're ramping up your program in the post-COVID world. So I think with a little bit of luck, you may manage to get away with it, and COVID shouldn't have too much of an impact. So I hope I've persuaded you not to worry too much about the WHO targets, because I think they're going to change, and I think that will be a change for the good. It will make it easier to persuade your government that you are succeeding. I hope I've given you some comfort in your elimination drive. I think you can do it. You have a very good model from Egypt. You have an excellent starting position. There are some genotype 3 related problems that we need to work through, but you have teams of good people already starting to apply themselves to those issues. So I think you're in a good position. What else do you need to do? What else can we do? Well, I'm afraid it's the basics. Getting rid of hepatitis C is not just about treating, it's about scaling up prevention. And I've said at the very beginning that this is not a very glamorous activity. Cutting needles in half so they can't be reused is not the way you win a Nobel Prize, but it's the way you stop your people catching hepatitis C. So I think scaling up prevention is really important and perhaps something we're not thinking enough about. We do need to scale up treatment, and there are ambitious plans underway, and I think that's going to be really important. I mentioned my slight anxieties about treatment failure. I think it is important to measure SVR. We know that if people take the drugs, they generally get rid of the virus. We know that the non-cirrhotic genotype 3 Hep C soft-ACT will cure 99% without a problem. I do worry a little bit about some of the cirrhotic patients, and I think it's going to be very important to measure SVR rates just to be sure that the drugs are doing what you think they're doing, and you need to be ready to perhaps think about adding in ribavirin or extending the duration if the response rates are dropping off. So please do think a little bit more about SVR in your elimination program. And my final concern is about liver cancer. And one of the concerns I have with any hepatitis C program is that as you diagnose more hepatitis C, you're going to be finding more hepatitis C cirrhosis, and they need screening. And not only will they need screening, you'll find more cancers with hepatitis C, so your cancer rate will rise. In any elimination program, we want to get people treated, move on, get the next one treated. So for anyone in my group who doesn't have cirrhosis, we throw them out of the clinic as soon as we've got an SVR12. We really don't have the resources to keep following people up. But of course, if you have cirrhosis, we commit people to 6 monthly ultrasounds for the rest of their life. As we find more patients, my ultrasound list is getting longer and longer and longer. And I'm not sure we can do that. And certainly in Pakistan, you're not going to be able to follow up very large numbers of your population with 6 monthly ultrasound scans. And I think the way forward here is going to be to stratify. There are lots of algorithms starting to emerge looking at risk factors for liver cancer. It is, I'm afraid, being male. Diabetes is a bad risk factor. Alcohol is probably not going to be a major concern in Pakistan. But genotype 3, I'm afraid, is the most cancer-causing virus. So here are various models. Lots of different people are playing with data, looking at risks of cancer, and coming up with these very complicated algorithms. I don't want to labour the point too much, and certainly you shouldn't go concentrating on this slide. But if you just look at the chart, the model, you can see that for some people with cirrhosis, the risk of liver cancer is actually quite low. Here's a group of people with a low risk of liver cancer in a cirrhotic patient. But some people without cirrhosis, particularly those with genotype 3, high AST-ALT ratios, they have quite a high risk of cancer. So I think we're going to have to get much more sophisticated in the way we stratify patients for malignancy. We may need to use viral subgenotyping. We may need to do more genotyping, perhaps more pre-treatment workup, so that we don't have to follow everyone up with 6 monthly ultrasound scans. So this, I think, is a really important area to focus on over the next few years. Which of your patients needs follow-up for liver cancer and which of them don't? So my final recommendation is that I think the end is in sight. I really do believe that hepatitis C is a tractable virus. It's a virus that we can eliminate even without a vaccine. I think the way to do that is to push for very careful control of viral spread. We really do need to get on top of needle reuse and stop it happening. We need to focus on prevention every bit as much as treatment. We also need to plan a little bit for enhanced treatment. We need to make sure we're measuring SVR12. need to make sure that if people are unlikely to respond to our first-line treatment, we have rescue strategies. We need to make sure that we don't allow resistant virus to seep into the population and cause more trouble than it's worth. So we do need just to be a little smarter on the way we measure our response rates. And I think we do need to develop some markers for liver cancer. I think there is a very real threat that we will turn the hepatitis C epidemic into a liver cancer screening epidemic that will soak up large amounts of our healthcare resources. I do believe that with a cancer rate of 3% after treatment, we can refine it so we don't have to screen everyone with cirrhosis. I'm sure we can develop better algorithms. I think that's going to be a really important area of research over the next few years. Who needs screening and who doesn't? And my final message is one of hope. If you'd said to me 5 years ago, Egypt will eliminate hepatitis C by 2020, I'd have laughed at you. I really would not have thought that a country with that disease burden, with that geography, could ever have reached the stage of eliminating hepatitis C, but they have. And they've done it way ahead of everybody else. So I really do believe that hepatitis C can be beaten. We now know what we need to do. We've got some fantastic data from Pakistan telling us where to look, where to go. We've got fantastic access to drugs. We have political will. And I really do believe that Pakistan can put itself into that select group of countries where hepatitis C is a disease of the past. And I hope that you will work with us. I hope that we can help you on the way, because I really do believe that hepatitis C in Pakistan could become a thing of the past. Thank you very much indeed.
Thank you so much, sir, for such a brilliant lecture. It's really an honor for all of us to be your audience. Our final honorable guest of the event is Dr. William Alazevi from the United Kingdom. Dr. William Alazevi is a reader and consultant hepatologist at Queen Mary University of London and Bord's Health NHS Trust. He qualified from the PhD program in Cambridge and trained at Addenbrooke's, Hammersmith, Royal London and King's College Hospital. Dr. William Alazevi is going to enlighten us on easy debrief on NAFLD and NASH.
Good evening. My name is William Alazevi and I'm Professor of Hepatology at Queen Mary, University of London. It is a real pleasure to speak at the Pakistan Society of Hepatology, even if this year I'm talking to you from my office in a wet and rainy London. I would like to thank the organisers for inviting me to give this talk, summarising the main findings at the European Association for the Study of the Liver International Liver Congress 2020. This year's digital ILC saw hundreds of abstracts covering basic, translational, and clinical science. So summarising all that work has proven somewhat challenging, and I've had to select some of the presentations that particularly caught my attention. I apologise to the investigators of the many excellent studies that I have not been able to include in this talk, and I hope they will forgive this omission. Here are my disclosures. An important focus of this year's ILC has been a better understanding of the epidemiology of fatty liver disease. Petter and colleagues reported the results of a meta-analysis of studies into the prevalence of NAFLD, NASH, and advanced fibrosis. They identified 42 studies from 15 European countries that comprised over 125,000 adults. Overall, their estimate from a random effects meta-analysis model was that the prevalence of fatty liver disease was 27.6%. They identified 12 studies that reported the prevalence of NASH. Among almost 4,700 patients with biopsy-proven NAFLD, 64.3% had NASH, although of course we do not know the indication for biopsy in the studies or for the individual patients. They also identified 5 studies that reported the prevalence of advanced fibrosis in the general population to be 6.1%. So these estimates are very helpful for those of us working in this space, but also it reminds us that there is a diagnostic gap in NASH and fibrosis. Remember as well that these data are all from European countries, so similar studies in other territories and regions around the world are needed. Alongside epidemiology, we saw studies into natural history. Reinhardt and colleagues looked to create a machine learning model that could augment clinical decision-making and identify NASH patients who are at risk of fast progression. They used electronic healthcare record data from 4,400 United States patients with ICD-9 and 10 codes for cirrhosis or hepatocellular carcinoma due to NASH. They determined time to progression retrospectively, calculating from the time of cirrhosis or hepatocellular carcinoma back to the first diagnosis in the record of NAFLD or NASH or one of a list of proxy diagnoses. The model could distinguish fast progression, which the authors defined as taking place in under 3 years, from standard progression, which they defined as greater than 6 years, based on 44 data elements with an area under the receiver-operator curve of 0.77. The authors suggest that such algorithms may be useful to support physicians' treatment and management choices. Machine learning featured in a study by Pakala and colleagues who looked at the histology from over 1,500 patients with F3 and F4 fibrosis due to NASH who took part in the STELLA-4 study in order to identify features of disease progression. They used an artificial intelligence platform to train a convoluted neural network. Progression, that is from F3 to fibrosis, or from established F4 through to a liver-related event, was associated with features including presence of ballooning, portal inflammation, and more areas on the histology slide with advanced fibrosis. In order to understand this relationship between inflammatory cells, and fibrosis, Tuari Heckler and colleagues built on an earlier observation that circulating blood levels of adenosine deaminase 2 protein, that's ADA2, correlated with liver fibrosis in non-alcoholic fatty liver. They reasoned that as ADA2 is produced exclusively by monocytes and macrophages, that ADA2 and its product inosine may modulate the phenotype of hepatic macrophages. Indeed, they demonstrated that in 92 liver biopsy specimens, portal macrophages that were positive for ADA2 were significantly associated with the degree of liver fibrosis. In vitro, using human-derived liver spheroid models, the addition of recombinant ADA2 led to an increase in the expression of platelet-derived growth factor, PDGF, which is a key pro-fibrotic cytokine. ADA2 also led to the increase in expression of pro-inflammatory and fibrotic genes in monocyte-derived macrophages taken from 6 donors. It also led to an increase in PDGF expression. The same was seen when the substrate for ADA2, that is adenosine, was added to the culture. And the same again was seen when inosine, the catalytic product of ADA2, was added. However, when the catalytic site in ADA2 was mutated, this induction of PDGF was lost. So the authors here have presented a number of lines of complementary data, all of which point towards a possible mechanism by which infiltrating inflammatory monocytes can induce a pro-fibrotic phenotype in hepatic macrophages and thereby promote fibrosis. Moving on to genetics, Bianco and colleagues looked at the utility of an existing polygenic risk score for hepatic fat content to determine the risk of hepatocellular carcinoma in a multi-center cohort. So this existing score is based on common variants of the PMPLA3, TM6, SF2, MBOAT7, and GCKR genes, all of which have been associated with fatty liver. The polygenic risk score predicted hepatocellular carcinoma in 226 patients out of a total of 2,500 in the cohort with an area under the receiver operator curve of 0.64. A positive polygenic risk score for hepatic fat content was associated with an odds ratio of 3 for hepatocellular carcinoma. One of the things they set out to do was to see whether or not the addition of HSD17B13 to the polygenic risk score increased its performance, but they did not find that this had any effect. An emerging theme, both in this meeting and also in the literature over the last few years, has been to study the role of skeletal muscle as a metabolically active organ. Natchett and colleagues from Belgium used CT scanning to determine the presence of myosteatosis in preclinical mouse models of simple steatosis and of NASH, and in people with obesity who have biopsy-proven fatty liver or NASH. High-fat diet-fed FOS mice with NASH showed a loss of muscle strength and a relative decrease in muscle mass. The earliest muscular change they observed in the mice was a reduced muscle density on CT, which indicated myosteatosis. In a human cohort of 185 patients with biopsy-proven NASH, compared to those with uncomplicated steatosis, they saw a distinction in the degree of myosteatosis. This slide, this CT scan, is taken from the talk itself. On the left, you've got a patient with fatty liver alone, and on the right, a patient with NASH and fibrosis. The blue areas in the muscle indicate lower density in keeping with myosteatosis. That myosteatosis was closely correlated with the presence of NASH, and the authors suggest that this may be therefore used as a non-invasive marker of NASH. Adipose tissue inflammation and insulin resistance are features of metabolic syndrome, type 2 diabetes, and obesity. Gastaldelli and colleagues investigated the possible link between these features and hepatic lipid metabolism and the severity of NAFLD or NASH. They measured circulating markers of each of these processes in 318 patients with histologically characterized fatty liver, of whom 188 had NASH. They found that measures of adipose inflammation in the form of circulating adipokines and of insulin resistance were increased in patients with NASH. However, products of mitochondrial beta oxidation reflected by levels of beta hydroxybutyrate did not differ between these groups. Adipose tissue insulin resistance was associated with circulating triglycerides and inflammatory adipokines, and was more strongly associated with steatosis than with NASH or fibrosis. So taken together, this study and the previous study emphasize the involvement of different organs in NASH progression. And they also begin to speak to that close association between metabolic dysfunction and inflammatory changes. Govari and colleagues have focused on the pro-inflammatory activation of macrophages by saturated fatty acids. They hypothesized that the macrophage scavenger receptor, MSR1, may mediate this activation. So in this paper, they present multiple lines of evidence to support their hypothesis that there is an association between MSR1 and NASH. So firstly, in mouse models, they show that mice that lack MSR1 are protected against diet-induced hepatic inflammation and fibrosis. They measured reduced circulating fatty acids, hepatic triglyceride levels, and they also noted more lipid storage in the adipocytes of the mice. Looking at liver tissue from patients with fatty liver disease, they observed MSR1 expression was increased. Genome-wide association study analysis in nearly 1,500 European Caucasians with biopsy-proven fatty liver revealed a statistically significant association with 4 single nucleotide polymorphisms at the MSR1 locus. Quantitative trait analysis for the most significant of these SNPs in 430,000 patients taking part in the UK Biobank project showed a significant correlation with serum triglycerides and ALT levels. So the authors have suggested that these data indicate that MSR1 is a sensor for lipid homeostasis, and they go on to propose that this may even be a potential therapeutic target for the treatment of fatty liver. This year, we saw a large number of clinical and preclinical studies of pharmacological agents for the treatment of NASH and fibrosis. And I am grateful to Luca Valenti for sharing this slide with me that summarizes those studies that were presented as oral abstracts and refer to clinical trials. You can see that there's a broad range of agents at different stages looking at slightly different populations. A subject of discussion has been whether or not it might be possible to predict histological outcome in studies with earlier non-invasive changes. Rohit Lumba addressed this question in this abstract, which looked again at the resmetirom phase 2 study that has been published by Harrison and colleagues. Just to remind you, in this trial, patients with biopsy-proven NASH with fibrosis stages 1 to 3 and greater than 10% liver fat on MRI were randomized 2-to-1 to receive placebo with a primary endpoint based around a liver biopsy at week 36. Patients also had an MRI to determine PDFF at week 12. What they found was that the responders to resmetirom with more than 30% proton density fat fraction reduction at week 12 had higher rates of NASH resolution, that's 37% at week 36, compared to the non-responders, which was only 4%. They found that a cutoff of 41.5% could predict NASH resolution with good predictive values. This raises the possibility that there may be on-treatment or early indicators of histological response, which will be very informative in subsequent studies and eventually in real-world usage of drugs. Looking at some of these studies in a bit more detail, I'll highlight this study of aldafermin, which is an engineered analog of FGF19. FGF19 is induced by the FXR and regulates bile acid synthesis, a pathway that is known to reduce hepatic steatosis, inflammation, and fibrosis. This late-breaker abstract by Harrison and colleagues reported the results of 24 weeks aldafermin versus placebo in 78 patients with biopsy-proven active NASH and fibrosis stages F2 to 3 and MRI-determined liver fat content of greater than or equal to 8%. The study met the primary endpoint with absolute reduction in proton density fat fraction, and the authors report good tolerability. There was also evidence of improvement in some histological parameters. The authors report 22% of patients taking aldafermin achieved a greater than 1-stage improvement in fibrosis and resolution of NASH with no worsening of fibrosis, although this was not the primary endpoint of the study. Cotatatide is a GLP-1 receptor and glucagon receptor agonist and is currently undergoing trials in overweight and obese patients with type 2 diabetes. This abstract presented the results of a study in 834 such individuals who were randomized to 3 doses of cotatatide, liraglutide, a GLP-1 receptor agonist, or placebo in combination with metformin for 54 weeks. At baseline, 91% of participants had fatty liver based on a fatty liver index of greater than or equal to 60, and 13% had a NAFLD fibrosis score that was consistent with advanced liver fibrosis. The mean weight in all 5 arms was approximately 100 kilograms and did not change in the placebo arm. Weight loss was comparable in the liraglutide and the 2 lower doses of cotadutide arms and was greatest in the 300 milligram arm. The authors report reductions in ALT and AST in the higher doses and reductions in the fatty liver index and NAFLD fibrosis score values, although the proportion of patients changing fibrosis risk category is unknown. So, behavior and lifestyle change, particularly dietary interventions, remain the cornerstone of managing fatty liver and NASH, and a number of abstracts at this year's Congress reported the benefits of either diet or exercise, alone or in combination, on various features of fatty liver disease and metabolic outcomes. A ketogenic is one method of inducing weight loss that has been suggested by some to be effective in NASH, and it's also known to reverse steatosis and to improve insulin resistance. But the mechanisms by which a ketogenic diet does this in humans is not yet known. Lucanen and colleagues addressed this in a very elegant experimental medicine study that has since been published in PNAS. 10 adults with overweight or obesity underwent liver MR spectroscopy and elastography and metabolic studies before and after a 6-day ketogenic diet. The metabolic studies involved infusion of labeled glucose, hydroxybutyrate, and lactate, and this enabled the researchers to quantify endogenous glucose production, ketogenesis, and using an NMR-based technique called PINTA, hepatic citrate synthase and carboxylase fluxes could be calculated. And this can be used to assess flow through the beta oxidation or ketogenic pathways. Unsurprisingly, a ketogenic diet was associated with markedly lower carbohydrate and overall caloric intake. Beta-hydroxybutyrate and acetoacetate increased, and body weight, endogenous glucose, serum insulin, and liver fat content by MR all fell. The reduction in intrahepatic fat content was attributed to a net increase in hydrolysis of intrahepatic triglycerides and partitioning towards ketogenesis due to the reduction in insulin and hepatic citrate synthetase flux. The authors related these changes to a reduction in plasma leptin levels and also a reduction in triiodothyronine levels. So this study gives us insight into the mechanisms underlying reversal of steatosis by ketogenic diet, and I think reading the full paper is highly recommended. It has been an honor and a privilege to be part of this digital conference, and I hope we'll all be able to meet in person when the circumstances permit.
Thank you so much, Dr. William Alazevi. It was an excellent presentation. At the end, I will request our worthy facilitator, Javed Iqbal Farooqi Saab, and our honorable chairpersons, Professor Kashif Malak and Altaf Bakir Saab, to give their insights about these burning topics.
Yeah, thank you, Iqbal Heather. Altaf Bakir Saab, I would like to have your comments, brief comments on the session, and then Kashif Malik Saab. Altaf Bakir Saab, are you with us? Kashif Malik bhai?
Ji, Dr. Farooqi, I'm very much here. It's a very nice elaborated talks by all the 3 speakers, and I really enjoyed it. And it's already too late, and it's a state-of-the-art lectures. So it's midnight here in Pakistan, and we have to start tomorrow morning by 8 a.m. I think nothing else I can say. So I thank you all the three speakers for their talks, and now you can conclude the session.
Well, thank you, Professor Kashif Malik. It remains my duty to pay officially thanks to my chairpersons, moderator, and all the three speakers on behalf of the Pakistan Society of Hepatology. No doubt these were wonderful talks, and I hope that we have some reasonable attendance to start with tomorrow morning. So from our side, it's good night. Stay safe and see you tomorrow. Thank you very much. Thank you,
Iqbal,
Iqbal. You can, yeah, Altaf, go ahead.
Iqbal, can you unmute Altaf Bakir, please?
Yeah, can you hear me?
Yeah, okay.
Yes, Dr. Altaf Bakir, we can hear you.
Yes, all the three talks were of high quality, and I should say Bilal highlighted the importance of impact of COVID on the practice of hepatology, and we learned with COVID how to deal with it in form of telemedicine and how to prioritize. Dr. William outlined the hepatitis C 2030 are we on the track, and I think the message was where there is will there is a way, so we can do it. Dr. William Alazevi presented the EASL debrief of NEFELD and NASH, and he presented the European data, prevalence and pathogenesis. I think all the talks were of high quality, and I appreciate all the three speakers. Thank you.
I see in the panelists, the Graham Foster, Mr. Saab, on behalf of the Pakistan Society of Hepatology, we are really thankful. You explained the Pakistan perspective regarding the HCV elimination. That was a wonderful talk. We enjoyed, we learned a lot, and I hope that we hear you tomorrow again. So thank you very much. For your final comments, sir.
Always a pleasure to talk to my good friends and colleagues in Pakistan. I appreciate it's terribly late, and I look forward to catching up tomorrow. Sleep well, and look forward to another exciting day tomorrow.
Thank you very much, sir. Thank you. We are really honored.
Goodbye. Good night.
You can call off the meeting.
With this, on behalf of PSH, I am thankful to all our worthy speakers, facilitators, chairpersons, and participants of this session. So with these remarks, I'm concluding this session, and have sweet dreams at this weekend, and enjoy another and last day of PSH 20. God bless you all, and Khuda Hafiz.
8 a.m. tomorrow morning.
Inshallah.
NEFELD.
Khuda Hafiz.
Allah Hafiz.
Thank you. Okay.